Hello everyone. I'm myself Dr. Rajesh Gubba. So I welcome you all to this INI-CT revision series. So as a part of the today's INI-CT revision series, the topic for the discussion is the respiratory disorders. So I'll give you the various clinical scenarios of the respiratory pathologies and you should be telling me like what exactly is the etiology of that respiratory problem in the patient. Now, yes, so before going ahead with the discussion, for any further updates related to the general medicine, you can follow my Instagram handle, that is Rajesh Gubba. Now, a multiple choice question. What is the drug of choice for extrinsic allergic alveolitis? The options are the prednisolone, then cyclosporin, azathioprine, cyclophosphamide. So you please answer this question in the comment box. I will revert back to you. Okay. Now, so these are all the various clinical scenarios, right? And you should tell me like what is the likely cause for the clinical finding in the patient which has been given to you. So the first important clinical scenario is a 21-year-old man has a productive cough, wheeze, and steatorrhea. On examination, he is clubbed and cynosed, and the patient has bilateral coarse crackles. What will be the diagnosis in this clinical scenario? Among the options which, okay, first and foremost, very important finding is productive cough, wheeze, and steatorrhea. So among the options which has been given to you, like which option or which clinical scenario has the productive cough along with steatorrhea? Go through all the options: pleural effusion, pulmonary edema, right-sided rib fracture, pneumothorax, bronchogenic carcinoma, pneumonia, fibrosing alveolitis, extrinsic allergic alveolitis, anemia, pulmonary embolism, ARDS, and cystic fibrosis. And the patient is also clubbed. So among the options which has been given to you, clubbing is seen in patients with bronchogenic carcinoma. Clubbing is also seen in patients with fibrosing alveolitis. Clubbing is also seen in patients with cystic fibrosis. But among these three options, like bronchogenic carcinoma, fibrosing alveolitis, and cystic fibrosis, the clinical scenario where you have the clubbing and steatorrhea is cystic fibrosis. Now, let me tell you, or let me give you a quick recap on the topic of the cystic fibrosis. It's an inherited disorder. What type of inheritance is this? It is an autosomal recessive type of inheritance. And this cystic fibrosis, it is due to gene mutation, that is CFTR gene mutation, which is present on the chromosome 7, right? Which is present on chromosome 7. And these patients, they are susceptible for recurrent respiratory tract infection. And because of recurrent respiratory tract infection, the individual has high tendency of development of the bronchiectasis. And these patients with cystic fibrosis, they can have acute exacerbations, and these acute exacerbations are often caused by the Pseudomonas species, right? Are often caused by Pseudomonas species, which is highly resistant to the antibiotics. And in these individuals with cystic fibrosis, if there is presence of hemoptysis, that indicates the presence of the aspergilloma, right? That indicates the presence of aspergilloma. And these patients, why do they have steatorrhea? In patients with cystic fibrosis, there will be also pancreatic insufficiency. So pancreatic insufficiency usually develops because of, pancreatic insufficiency is the one which will cause malabsorption and as well as the steatorrhea. And in these individuals with cystic fibrosis, there will be also growth and puberty being very much delayed. Males, they have infertility. Why the males are infertile? That is because of failure of the vas deferens and epididymis to develop. Vas deferens and epididymis, they cannot develop, and that is the reason why the males, they are usually infertile. And how will you diagnose this cystic fibrosis? That is by the presence of high sweat sodium and chloride concentration. That will be nearly around 60 millimoles per liter. That is highly suggestive of the cystic fibrosis. Now, this is the first clinical scenario. The answer was cystic fibrosis. And you take the second clinical scenario. A 23-year-old man presents to the accident and emergency with weight loss, cough, and hemoptysis and shortness of breath. On examination, he is anemic, clubbed, and as well as apyrexial. Now, what is the clinical diagnosis? See, among the among the options which has been given to you, what is a clinical condition where you have hemoptysis and as well as clubbing, shortness of breath and weight loss? Among all the options which has been given to you, you will have these in case of the bronchogenic carcinoma. So let me just give you the respiratory disorders where all you have the presence of clubbing. One is bronchogenic carcinoma, tumor arising from the pleura, that is mesothelioma, bronchiectasis, lung abscess, empyema, cryptogenic fibrosing alveolitis and cystic fibrosis. And please remember, COPD and asthma, these are not the causes of clubbing, right? These are not the causes of clubbing. Okay, so this is about the second clinical scenario. And you take the third clinical scenario. A 65-year-old man presents with shortness of breath and cough, which is productive, and the color of the sputum is pink frothy sputum. The patient is also cyanosed, and on auscultation there is also end inspiratory crackles. His jugular venous pressure is elevated. So among the options which has been given to you, where do you have this clinical scenario? You will have this clinical scenario in cases with pulmonary edema, and this pulmonary edema, it should be secondary to left ventricular failure. Pulmonary edema, it can be of respiratory cause also, that is in ARDS. But in ARDS, you will not have the pink frothy sputum. Whereas left ventricular failure causing pulmonary edema, there will be the pink frothy sputum. And in left ventricular failure, why there will be pulmonary edema? Because when there is left ventricular failure, there will be increase in the pulmonary capillary wedge pressure. So once there is increase in pulmonary capillary wedge pressure, that will cause leakage of the RBC into the alveoli. So once there is leakage of RBC into the alveoli, that is the reason why the sputum, it is often pink in color. Okay, that is due to leakage of the RBC into the alveoli. So for the third clinical scenario, the answer is the pulmonary edema secondary to left ventricular failure. And fourth clinical scenario, if you see, a 70-year-old woman presents with fever, rigors, shortness of breath and right-sided pleuritic chest pain. On examination, the right side of the chest shows reduced expansion, dull percussion note and increased vocal fremitus. So among the options which has been given to you, what are the clinical conditions where you have dull percussion note and increased vocal fremitus with fever, rigors, shortness of breath and right-sided pleuritic chest pain? That you will have in clinical scenario, that is in pneumonia. So you should not get confused with the pleural effusion or pneumothorax because of reduced chest expansion is being present. Reduced chest expansion can be there in pneumothorax and pleural effusion also, but in pneumothorax and as well as pleural effusion, tactile vocal fremitus is reduced. It is not increased. So the answer in this clinical scenario is pneumonia. And the last clinical scenario, a 30-year-old farmer presents with repeated episodes of fever, rigors, dry cough, shortness of breath with onset of several hours after starting work. On examination, he is pyrexial with coarse and expiratory crackles. Chest radiograph shows mid-zone mottling. So what do you think is this clinical scenario suggestive of? This clinical scenario, it is suggestive of extrinsic allergic alveolitis. Now what is this extrinsic allergic alveolitis? Extrinsic allergic alveolitis, it's a hypersensitivity reaction to an inhaled antigen. Right, hypersensitivity reaction to an inhaled antigen. Now, what is this antigen? This antigen is thermophilic actinomycetes or Aspergillus clavatus. These are the antigens which are responsible for inducing extrinsic allergic alveolitis. And pulmonary function tests show reversible restrictive defect. That means your FEV1 by FVC will be more than or equal to 70%. That is what you mean by the word restrictive lung disease. And how will you diagnose this extrinsic allergic alveolitis? There will be presence of serum precipitating antibodies. Right? There will be presence of serum precipitating antibodies. And when you do a chest radiograph in chronic allergic alveolitis, there will be honeycomb appearance. And what is the drug of choice in case of acute cases? that will be corticosteroids. So finally, what is the drug of choice for extrinsic allergic alveolitis? Go through all the options and please mention the answer in your comment section, right? And this is a table, very, very important table of various respiratory disorders and what will be their respective findings. So the first one is the tracheal position. The second one is the percussion note. Third one is like what will be the type of breath sounds. And the fourth one is the vocal phreatitis. And is there any added sounds? So this is the table which you can go through. Definitely you will have an added advantage. Thank you very much. See you tomorrow again.